Now let's come to discuss the lower GI disorders of the colon. And here we're gonna discuss inflammatory bowel disease, irritable bowel syndrome, and we'll talk also about two important symptoms, manifestations of lower GI disorders, diarrhea and constipation. Let me start with the inflammatory bowel disease. And we have two distinct diseases that constitute this inflammatory bowel disease: Crohn's disease and ulcerative colitis. So inflammatory bowel disease could be because of Crohn's disease or ulcerative colitis, both of which we do not know exactly the exact cause of both of them, but we believe to be some autoimmune. There is a strong autoimmune evidence, strong autoimmune contribution to the pathophysiology of Crohn's disease and ulcerative colitis. Crohn's disease and ulcerative colitis, inflammatory bowel syndrome, inflammatory bowel disease, and they result in severe inflammation in the gut. And both will present with fever, abdominal pain, diarrhea, blood in stool, weight loss. Notice you have local manifestations of inflammation, abdominal pain and diarrhea, blood in stool, as well as systemic manifestations of inflammation, fever and weight loss. You have both manifestations of inflammation, local and systemic. They also will present with extra-intestinal manifestations. The manifestations of inflammatory bowel disease is not just confined to the GI, they have extra-intestinal manifestations. They present with joint pain. They affect the joint and you get arthropathy. They affect the eye. You have iritis or uveitis, some skin findings, pyoderma gangrenosum and erythema nodosum. These are the extra-intestinal manifestations of inflammatory bowel disease. And also they can result in sclerosing cholangitis when they affect the colon. Well, ulcerative colitis always affects the colon, but 40% of cases of Crohn's disease will have colonic affection, and this is where you're going to get this complication of sclerosing cholangitis, inflammation of the bile ducts. Which one can lead to cancer? The answer is both of them. Both of them can lead to colon cancer. That's why, very important, we should start annual colonoscopy after 8 to 10 years of colonic involvement. When your patient asks you, when your patient with ulcerative colitis or Crohn's disease asks you, when do I need to get endoscoped? When do I need to be followed up for cancer? Your answer is going to be 10 years after your initial diagnosis with either Crohn's or ulcerative colitis. We're going to start doing annual colonoscopy for you. Let me differentiate between Crohn's disease and ulcerative colitis. We have just seen what's common between them. Both present with abdominal pain, blood in stool, diarrhea. Both present with extra-intestinal manifestations. Both can lead to colon cancer. What's unique to each one of them? And let me start with Crohn's because it's kind of more widespread. Crohn's disease is a disease that affects all the layers of the colon wall or of the gut wall. That's why we call it transmural disease. It affects all the layers. It does not just affect the superficial layer, no, it affects all the layers. It's transmural. But we have some skip lesions. Some areas are quite normal and other areas are very, very affected, and the whole thickness of the gut is affected. And Crohn's disease can affect the upper GI or the lower GI. Crohn's disease can affect any part of your GI tract, starting from mouth to anus. Crohn's disease can affect any part. No part is immune in your gut against Crohn's disease. But you have skip lesions. Not all areas in your GI tract are going to be affected. And the affected area, the whole thickness is going to be affected. That's why we're going to see a lot of strictures. We're going to see a lot of fistulas because you damage the whole thickness, and this gut wall might be perforated and opens to another gut cavity, and we develop fistulas. Even the gut can open to the skin, and you can have like multiple anuses from your skin because of these fistulas and strictures and masses, because Crohn's disease is transmural. A very important finding in Crohn's disease, and very interesting one, hypocalcemia, and cholesterol gallbladder stones, and calcium oxalate kidney stones, and vitamin B12 malabsorption. Vitamin B12 malabsorption when Crohn's disease affects your ileum, where you absorb vitamin B12, and also you can get perianal manifestations. Don't forget, Crohn's disease can affect any part in your GI from mouth to anus. On the other hand, ulcerative colitis, as the name implies, where do you expect to see it? Colon and rectum only. Colon and rectum only. And it is superficial mucus affection only. Ulcerative colitis is not transmural. Ulcerative colitis does not affect the whole thickness. I do not mean by any means to say that ulcerative colitis is the milder form of inflammatory bowel disease. Both are bad. Both can lead to colon cancer. Both are severe inflammatory bowel diseases. But I'm just highlighting the major differences between these two inflammatory bowel diseases. Ulcerative colitis affects the superficial layer only, the mucosa only. Ulcerative colitis will affect the colon and the rectum. Ulcerative colitis will result in more sclerosing cholangitis. Why? Because it affects the colon only. Ulcerative colitis has no transmural affections, so no fistulas, no strictures, no masses. Diagnosis of inflammatory bowel disease, one word: endoscopy. Colonoscopy. You should do colonoscopy. Barium studies could be done, but again, you need to do colonoscopy and some antibody testing, because it is an autoimmune disease, so you will see elevation of ASCA and ANCA, but the table is here for you if you want to go deep into this. Treatment of inflammatory bowel disease. How to treat this inflammatory bowel disease? The key word here is inflammatory. Now we have a severe inflammation. How are we going to treat? The keystone in treatment is aminosalicylate preparations. Salicylate is a potent anti-inflammatory medication, and the drug of choice, the best initial therapy for inflammatory bowel disease is mesalamine. Previously, we used to use sulfasalazine, but sulfa can result in allergy in 10% of the population and has a lot of side effects. So now the treatment of choice for inflammatory bowel disease is mesalamine, and mesalamine comes with different brand names: Pentasa for Crohn's disease, Rowasa, and Asacol. Rowasa is a rectal aminosalicylate, Asacol for ulcerative colitis, and Rowasa, it's a rectal aminosalicylate. It's a rectal preparation. Steroids. Budesonide is the steroid of choice. If the patient does not improve just on mesalamine, or the patient has acute exacerbation of the condition, we can add a steroid, but we do not want to have a lot of side effects of these steroids. So we can use steroids like budesonide. The beauty about budesonide is you give it and it stays in the gut, it stays in the colon, and once it goes to the liver to be metabolized, the liver destroys the majority of it. So there will be no budesonide reaching your systemic circulation, and you will not get systemic side effects of steroids. Azathioprine and 6-mercaptopurine, in case steroids are not very effective, we use these strong immunomodulator agents. Infliximab is a recent tumor necrosis factor inhibitor. It controls Crohn's disease with fistulae. Metronidazole and ciprofloxacin are especially effective in Crohn's disease that affects the perianal area. Perianal Crohn's disease, this is the time for metronidazole and ciprofloxacin. When are we going to do surgery? Well, surgery is curative in ulcerative colitis. You do what? Colectomy. You remove the colon. Of course, if you don't have a colon, you don't have anything to inflame. Ulcerative colitis. If you don't have a colon, you will not have this ulcerative colitis. In Crohn's disease, the indication of surgery is fistulas. You have to do. Fistula cannot be cured by any medication. You have to do surgery. But the bad news is fistula will recur after surgery. What to do? Another surgery. And this what makes Crohn's disease a very miserable disease to manage. And the two extra intestinal manifestations that do not go away with treatment are the skin manifestation, pyoderma gangrenosum, and the sclerosing cholangitis.